Hopefully you guys can hear me now. Today's talk is going to be on bunions and specifically the Lapiplasty, which we're going to get into. So that is me, upper corner here, Scott Smith, Podiatry, Monterey Spine and Joint. I do the foot and ankle service here. I've been here for about 12 years, board certified, before that in private practice, wound care background, but special interest in bunion surgery, bunion repair, all things bunion. Today we're going to talk about the Lapiplasty, and I think it's going to be pretty interesting. So hopefully you guys will learn things from this and we can answer questions. So let's talk about bunions. So quick background, there's over 100 procedures for bunions. And the bunion, just to give a snapshot, most of you probably already know this, is the bump that you see on the inside of the foot, and it sticks out. It can be painful in shoes. It can be painful with weight-bearing activities. You can get joint pain. Pretty common, and there's many treatment options. And again, over 100 bunion surgeries. We're going to talk about which ones work, which ones don't, the different trends that are out, and then ultimately leading to this procedure, which is now probably my favorite procedure to do. And we'll go over why. So Lapiplasty, FDA cleared since 2015. It is a procedure that is designed with a host of instrumentation that is used on a previous procedure called the Lapidus. So Lapidus was the original procedure designed to address bunions, and Lapiplasty came around and made some really impressive instrumentation to make the outcome very reproducible and allow patients to walk faster. So we'll get into that as we go along. And just to disclose, I have no consulting fee or anything with Triace or Lapiplasty. So I literally just do the procedure. I don't have any connection with the company other than using the product. So let's talk bunions. So here's a good picture of a bunion. So you can see here on the image on the right, you can see the first metatarsal, or the bump, that is coming out, and that's a classic bunion. On the left is a patient that does not have a bunion. So we'll talk and see how this goes, normal versus bunion, and the types of procedures and treatment you can do for it. And that's a good picture of a bunion, and they can be mild, moderate, severe, but in essence, it looks like that. Mild, moderate, or severe. So we see it all. Towards the left are the more mild ones, and as you get to the right, they become bigger. When the bunion becomes bigger, it can affect the joint. You can get arthritis in the joint. And you can also see some second toe hammering. It's common to have hammer toes with the bunion as well, but they can be mild, moderate, or severe. So the next thing is like, well, what kind of symptoms do you see with bunions, and how does it affect the rest of your body? So you can get pain in the joint, you can get pain on the bump. Oftentimes people will have pain in shoes with activity. And as the first ray, we call it the first ray, or the bunion, the first metatarsal starts to move out of place, it can affect the alignment of your knee and your hip because you start to pronate, which is where the foot kind of turns outward. So it can have more of an effect than just seeing a bump. So symptoms, again, pain, swelling, pressure, numbness. There's a nerve that runs on the outside of the bunion bump, and that can cause numbness and pain. Standing for long periods of time, and definitely different types of shoe gear. So oftentimes people say, what causes it? You can have a genetic predisposition. So somebody in your family has a bunion, biomechanical imbalances, or the foot type, high arch, flat foot, pronation. And different types of shoes, especially shoes that pinch or squeeze the toes, can also accentuate a bunion deformity. So those are kind of the reasons why you develop a bunion. And here are people that do different professions, even though I've never seen anybody that looks like any of these people in these professions. Yeah, maybe some, I guess the ballet dancer, maybe the construction guy. So, you know, it depends what you do. If you stand a lot, it can be more irritating. Athletes, we see it in everybody, young, middle age, older patients. We have something called juvenile hallux valgus, which are in essence adult bunions in children. So depending on what you do and what types of shoe gear and activity you have, the more it can become painful. This often comes up, shoe wear, high arched, you know, high heeled shoes, clearly not good for a big toe joint, and different types of footwear can cause increase in symptoms. So, you know, if you have a bunion and you're looking to treat it and you're not interested in surgery, wearing a shoe that has wider toe box and a supportive arch according to what your foot type is, the better. Bunions do continue to get more severe over time. Sometimes a good shoe or an orthotic can slow that down, but they typically get bigger and bigger over time. And there's no real way to correct that unless you anatomically realign it. So some of the things that can happen over time with a bunion: arthritis in that big toe joint, calluses, the second toe or the hammer toes can start crossing over. You can develop bone spurs and pain under the ball of the foot. So a bunion is not just a cosmetic thing, it affects the joint. And like any other joint, you can develop arthritis in that big toe joint. So different types of things conservatively to talk about. You can get an orthotic. You can wear a wider shoe. There's different types of toe splints. This is kind of an extravagant one. They have this thing called yoga toes now. And you can use different types of bunion splints. There's 1,000 of them on the internet. And they might help, but they won't get rid of the actual root cause of the bunion, which we're going to talk about. So to review conservative treatments, we talked about toe spacers, pads and splints, inserts, orthotics, and designed to keep you comfortable, but won't address the etiology or the reason why you have the bunion in the first place. More than a bump. So this is getting kind of important, and I hear this all the time. You see the circle around the bunion bump, and the arrow that is just under that, root cause of the bunion. Now that arrow is pointed at something called the metatarsal cuneiform joint. This is where the first metatarsal becomes unstable, and that's where the bunion starts. This will make more sense as we talk about this. And there is a misconception that you just shave a bunion bump off. This was an old procedure done a long time ago, and it really doesn't have a place in bunion surgery unless you fit a very specific category, somebody who's maybe in bed or bedridden with an ulcer. But any type of reconstruction or where you're trying to actually align the first metatarsal, it's not just shaving a bump off. So we have a few, it is a more complex deformity, and it all has to do with instability at that joint at the bottom arrow or the first metatarsal cuneiform joint. And here it's showing you the 3 areas that are very important in bunion surgery or in bunion repair. The unstable joint, which is what the Lapiplasty directly repairs, the metatarsal bone, and the 2 sesamoids. So those little small P-shaped bones, they're like the patellas of your first metatarsal, little bones, but have a big purpose in bunions and in bunion correction. So here we see an X-ray. So left normal, right bunion. You can see that first metatarsal is separating from the second metatarsal, kind of given the peace sign. And those little round sesamoid bones start to dislocate. So that's a very typical looking bunion on an X-ray. And you can see a good picture of that right there. So here's where we get into the interesting stuff. So The majority of bunions are a triplanar deformity. So what does that mean? That means that you have a deformity in the transverse plane, which is what you're seeing here when you see the bunion spread out like that. The sagittal plane, which goes up and down. So transverse is like this, sagittal is like this. And then the third and really important is the frontal plane that goes like this. Now, bunion surgery in the past has never addressed all three of these planes. This is what separates this procedure from the rest. So we're going to get into that. So this is a nice kind of analogy that we see, the Leaning Tower of Pisa. They kind of compare this to this, and it makes sense. So a three-dimensional problem with an unstable foundation. So it's leaning sideways, much like the Leaning Tower of Pisa. Here we have the sagittal plane. So the Leaning Tower of Pisa was the transverse. Now we're talking about the sagittal. And oftentimes the first metatarsal elevates up, and that's something else that you need to address. So that's the second plane or dimension of deformity in a bunion. And then the third and final one is the frontal plane, or this plane, and they compare it to tires on a car. Now in the past, we would release the sesamoids, move it over, but it would never really address this. With this procedure, you can align them back where they belong. This is the traditional two-dimensional bunionectomy. The most common name of this is called an Austin or a chevron bunionectomy, and this has been done for a long time, and it's still a good procedure, but it does only repair in two dimensions. This is what it looks like on the x-ray. You typically make a cut in the neck of the metatarsal, move it over, and reduce the bunion that way. And this will make more sense as we show more pictures. So the first part is shaving the medial eminence off there, or the medial part of the bone. They show this compared to the Leaning Tower of Pisa. So they say, like, well, if you wanted to repair the Leaning Tower of Pisa or make it straight, would you just shave a part of the Leaning Tower of Pisa off? No, you wouldn't, because it doesn't address that unstable foundation, which is the root of the problem right there at that joint that the arrow is pointing to. This is that Austin bunionectomy we were talking about, and this is a very common procedure, and it's still a good procedure. However, it's only a two-dimensional correction. So where the circle is, you see there's a cut through the bone is moved over, reducing the bump. And again, comparing it to this picture to the left, it makes no sense when you look at it in that regard. It typically looks really good clinically. However, on x-ray, it looks a little funny. And that's what this Lapiplasty does so much better. So you can see the x-ray here. So the bump is gone. So if you were to look at the foot clinically, you'd say, you know, it looks pretty good. But if you look at the x-ray, you can see that it doesn't address that unstable joint. And it just looks a little bit funny because you're correcting it at the neck of the metatarsal, not where it starts. So again, looks okay on the outside. So the picture on the left, that could be what it looks like, and it can look very good clinically. But on the x-ray, you can see that that joint where it all starts doesn't get addressed. And so it looks a little funny and crooked on the x-ray. So this is a slide they put up, but, you know, I've never really seen the pig with lipstick. I know people talk about it, but I guess what they're trying to say is, you know, you can make it look good, but not too great, especially because it's not addressing the problem. It is a cute pig though. Okay, so here's just some common facts. Here's another thing too. So if you don't get a three-dimensional correction, or if you get a procedure that was done where you're only addressing 2 out of 3 of those planes of deformity that we were talking about, you have a 12-time chance of getting a recurrence in the bunion. And there's no question that we see that, especially in younger patients and patients that have larger bunions. 1 in 3 people can have some dissatisfaction with a two-dimensional bunion surgery. That's either because of the joint or because of the recurrence. And It says here 70% of osteotomy patients experience recurrence over time. So it's showing you here that Austin bunionectomy is not right for everyone. And that in the past, there were a lot of bunion procedures that had complications that are eliminated with this procedure. And we're going to see, you'll see this firsthand here. So the whole purpose of this procedure is to address it correctly at its source the first time, as opposed to doing other procedures that may have the chance of recurrence. So now we're going to get to this particular procedure, or a newer solution for bunions. And this is what it looks like when you take a picture or an x-ray after the surgery. They all very much typically look the same. And you will see these images as we continue, and we'll talk about them. But in essence, you're seeing two plates at the metatarsal cuneiform joint, or that unstable joint where it all starts. And you're seeing roughly a 0-degree angle or complete anatomical alignment, with also sesamoid bone, or those little P-shaped bones, going back where they belong. So how does it work? It works by literally taking the first metatarsal and placing it where it needs to be in relation to the rest of the foot and the second metatarsal. And this device you're seeing here is called a positioner. And it's unlike anything that's ever been used in bunion surgery. It's a common device that's used in hip and knee and shoulder surgery, but this is the first one for bunion surgery. So you can literally put the first metatarsal where it needs to be, and everybody is different. So it depends on each person's foot. You take an image, you make sure it's in good alignment, and then you do the work with the positioner held in place so it holds a good, strong construct while you're correcting it. So this is the plating system. So once you get the bones and the bunion in the position you want it, you use a 2-plate fixation, very low profile plates. And the beauty of this procedure is that you address the bunion at its source. And by design, it allows for a little bit of motion through that joint and early weight bearing. So in the past, this is where this is separate this from every other procedure. In the past, it was all about correcting this in that area and then keeping you off your foot for weeks and weeks and trying to get the bone healing primarily. This is a different concept that encourages micro motion through there so you can get back walking sooner. These are before and after pictures, and they all roughly look the same. So bunion on the left, no bunion on the right, but even more than that, you can see that the first metatarsal is in perfect alignment with regard to the second, third, fourth, and fifth. You can also see that the joint, the big toe joint, is in alignment compared to the other side. And also those little P-shaped bones are back underneath where they belong. And you can do this, you can reproduce this every single time in every patient, doesn't matter how mild, moderate, or severe the bunion is. So comparing the distal or the 2-dimensional or Austin bunionectomy on the left versus the Lapiplasty on the right, and you can see the difference. One is curved and crooked, and the other is straight. Now, both of them would look okay clinically, but the point of the Lapiplasty is that it doesn't recur. It treats the unstable joint the first time, and it aligns the sesamoids because you can move it in the frontal plane, or that third dimension. So all that action is taking place at that joint on the Lapiplasty, but not on these other procedures. Now, here's another thing to look at. This is an interesting x-ray. So you hear a lot about minimal incision surgery. This is a trend that was very popular in the 70s and in the 80s, and then went by the wayside because it didn't work, and then came back in the 2015, 20s or whatever. And So the idea with this, and you may have heard this, this is very popular on social media, where you make a small stab incision, and under fluoroscopy, you basically make a blind cut in the bone, and you move it over and you percutaneously or fix them through small holes. So the patient comes out with an incision that's the size of a 5 millimeters, and it looks reasonable clinically, or when you look at it with your eyes. But this is what it looks like when you do an X-ray, and it makes absolutely no sense. So you're cutting a bone, you're moving it over, and you're putting these huge rod screw fixation in, or different types of devices, and it doesn't make any sense. And it's all for a small incision. So this is doomed for complication. And if you ever do see a minimal incision surgery, it has to be somebody absolutely spectacular in their field. Not everybody can do that, me included. I don't have any interest in minimal incision surgery. I would say there's one person up at UCSF that's got a good reputation, but this is something to really look out for. On the right, you can see the difference between a properly reduced first metatarsal that's in place, anatomically correct, well fixated, and looks like a foot. So that's like a picture's worth 1,000 words. These are other surgeries that we've done in the past. On the left, different base or a traditional lapidus. So again, the lapidus is what the Lapiplasty, it was basically the predecessor to it. And it was a procedure that was fraught with complications because it was very hard to fix, and it was easy to have not union or heal, and you couldn't walk on it for 4 to 6 to 8 weeks. So patients hated it, and it had a lot of complications. On the right, Lapiplasty, weight bearing within 1 to 2 weeks in a cam walker or a walking boot, with excellent anatomical alignment in all 3 planes. More examples showing you a normal foot and a post-Lapiplasty procedure. So what it's trying to show is that it is very close to a normal foot. Anatomically. So again, fix the root cause at that unstable joint, address the correction in all 3 planes. Again, the transverse plane, the sagittal plane, and the frontal plane. So in the past, 2, Lapiplasty, 3. So all 3. Walking in a boot within a couple of weeks versus being off your foot for weeks on end, and permanently securing that unstable joint. I know the people that have designed this product, and they've done great studies, and you can find a lot of these on the internet. You can look up Lapiplasty and you'll get tons of information. But there is no other 3-dimensional correction with this much success. Pictures, before and after. I mean, this is a picture of somebody about 3 months after the surgery. You'll notice there's a couple different incisions. There's one at the base or towards the midfoot, and a little one at the tip. And this is what it should look like, a before and after. But not just good clinically, or not just good on camera or in the office, but good on X-ray. More before and afters. You can just see how reduced that, how well you can address that bunion at that unstable joint. Before and after is again, and you can see these different types of incisions. I don't know if you've seen a bunion incision, but it's very minimal. You have a medium-sized one and then a very tiny one out kind of between the toes. So we'll talk about return to activity here. So what can you expect? So the way that I do this is the procedure takes about an hour and a half. And it's typically done at a surgery center or the outpatient surgery center at the hospital, depending on you and your medical history and things like that. But it's an outpatient surgery. It's covered by insurance, just like any other bunion or any other arthritic joint. And after the procedure, I have patients non-weight bearing for 1 week. So no weight bearing for 1 week, then walking boot, which is what you're seeing here, a little cam walker, and you're in that cam walker for 4 to 6 weeks. Now, in my experience, most people at the 4 to 5 week mark are getting out of their cam walker and into a running type shoe or a Croc or something that has width in the toe box and is a reasonable shoe. Depending on your activity level, and I've done this in people that don't do a lot, people that run, you know, hikers, athletes, etc. I would say that you're going to be doing more mild activity until the 3-month mark. If you're like a hiker or a you know, extreme athlete, or you want to do a lot of really load bearing exercises, you're looking at 3 months. Riding a bike, swimming, walking, you're looking at 8 weeks. So you can get back fairly quickly and very much in line with all of the other things that we were doing before, except for some of these lapidus procedures that we used to do in the past. Those were a lot longer. So reasonable recovery. Plate technology. So there's a lot of plates and screws that we use in bone surgery. This is an interesting concept because in the past you would make a cut in a bone and try to smash them together and then hold them with fixation. This is what we call docking. So we take the two sides of the bone after we prep them and we put them together, not smash them, but just gently dock them, and then use this plate technology to hold them in place, but also allow a little bit of motion. Motion is encouraged through this versus not moving anything. That separates this as well. So let's talk about what people are saying here. So these are just some quotes, you know, I mean, this is more of a company thing, but here's my opinion from the ones that I've done is patients are up and moving much quicker than anything that I've seen in the past. There's much less discomfort because you don't have to make as big an incision. It does not come back. So these are things that are important. And also, the fact that you can put these sesamoids back and you don't have to violate the joint like you did in some of these older procedures, you can move the big toe joint much quicker. Obviously, if you were to ever get to the point where you were a preoperative consult, we take time to talk about you know, different pros and cons of really any surgery. I'm frozen. Hopefully you can still hear me. I look like my dad right there. Okay, I'm back. All right. So again, they have a lot of stuff on alignmytoe.com. This is a really great company in regard to having information out there. They're constantly giving lectures so there's a lot of information out there. Okay. That's a lot of information, but we can chit chat about all types of bunion stuff. Let me go to chat here and see what's going on here. All right, hold on. Hopefully that wasn't too boring. It's a really cool procedure though. Okay, let's go here. Here we go. Hold on. There is no sound. We got that. Yes, there is sound. Here we go. Yes, yes, yes. A little bit of laughing. Will I address Taylor? Okay, first question. Will I address Taylor's bunions? Sure. Taylor's bunions are bunionettes or small bunions. So they're like a bunion that you get on your big toe, except you get it on your 5th metatarsal. Those are also treated roughly the same way. We don't have to do this type of procedure on a Taylor's bunion because the deformity is at the neck of the metatarsal. So wider shoes, orthotics, straps, and then the procedure of choice for that is either knocking a bump off or doing what's called a mini Austin bunionectomy. You can do a 2-dimensional correction on a Taylor's bunion because there are no sesamoid bones. So it's a bunionette or a smaller version of a big toe bunion. Thank you. Beautiful results. I love that. I agree. I agree. Okay, so do you eventually remove the hardware? Great question. No. Why? Because it's very, very low profile. So it has like maybe a 1.5 millimeter profile, so you don't even feel it. And so I haven't had to take any hardware out yet. It sits very well in there. It's deep and it sits comfortably on that bone. So typically, no. That it was a good question. What about doing stairs or driving if it's your right foot? Good question. So stairs, like we have that chat before too. One of the questions I ask is like, do you live upstairs? Do you live downstairs? It's more challenging if you live upstairs, obviously. You can do it with crutches. You can put some lightweight on the heel, and you have to be very mindful and careful using stairs. If it's your driving foot, I would say that if you're feeling comfortable within a couple of weeks, you can start to drive as long as you have an automatic. And as long as you feel okay pain-wise and are connected to your foot. So what I suggest to patients is they take their cam walker off, they put a post-operative shoe on, they drive, putting weight on the outside of their foot, not under the big toe. They get out of the car, they put the walking boot back on. So you can do that. How do you know your pain is from the bunion and not from possible lower back issues? Good question. If you have pain from a bunion, it will hurt when you press on it on the bump, or it will hurt when you move the big toe joint up and down. If you have pain in your foot, really, from the back, it will hurt at night and won't have anything to do with actual mechanical manipulation of your big toe. I don't see a lot of radiculopathy or lower back pain presenting as pain in the bunion. It's usually more on the top or outside of the foot, but that could happen. If it's going to be in the toe area, it's usually between the first and second toe in the inner space. Also, you can get, if there's really confusion, a nerve conduction study to rule that out. But they usually stand alone. I don't see a lot of crossover with that. Might be a dumb question, never a dumb question, but what is the difference between gout and a bunion? Are causes similar? That's a good question. So both, for the most part, while bunion is in the big toe joint, gout commonly presents itself in the big toe joint. Gout is inflammatory, becomes red, hot, and swollen right away, and there's no confusion with it. It looks like a hot red toe. That can develop into arthritis, or that can make a bunion that's already been there worse. So gout is an inflammatory condition, totally separate from a bunion, but can also cross over and make it worse if you have one already. And if you have a bunion already, you might be predisposed to getting gout there even further, because you already got some trauma in there, and gout likes to attack the big toe. That gives it more of a reason. So are the causes similar? I would say the causes, the only similarity is that it's in the big toe, but one is inflammatory and one is more musculoskeletal and biomechanical. Good question. What does 1 week of non-weight bearing mean? 1 week of non-weight bearing means you're not putting weight on your foot. So that means you're using crutches, or oftentimes I'll recommend a knee scooter, which you can rent these from places. They're real reasonable. And you've probably seen some people on this. You put your knee on it and kind of scoot, and it has a little handle and brakes and stuff. That's what I mean. So non-weight bearing means no weight on foot with use of crutches, knee scooter, or there's a couple other devices, but those are the two main ones. But if you think about it, 1 week non-weight bearing versus 4 to 6 weeks back in the day is pretty remarkable. How do you handle a patient with hammer toes as well? So typically, if you have hammer toe deformities with this, we repair those at the same time. For hammer toes, I typically use a product called a phalanx, Phalinx. And it's in essence a way to avoid using a K-wire, which are those pins that come out of the toe. You may have seen people with pins coming out of the toe. We can repair all this with a device where you don't have a pin sticking out of the toe. But it's important, if you have hammer toes, to also address them. You don't typically do one and not the other. Can you do both a bunion and Taylor's bunion during the same time? Yes. So that's another thing that's often done. If you have a bunion or hallux abducto valgus or bunion, and you have a Taylor's bunion, we would often repair those at the same time. And it doesn't affect recovery at all, because the Taylor's bunion is a quicker recovery than this Lapiplasty or really any bunion procedure. Do hammer toes go away? No. Hammer toes are typically here to stay. You can work on them with, these yoga toes and things where you try to stretch them out. If they're not hurting you, you don't have to do much. It's not like you have to do hammer toe surgery on somebody if they don't have pain or if it's not causing symptoms, but typically they don't just go away. They as the tendons pull and the hammer toe gets kind of worse and worse over time, you can start to feel it on the top. They typically get worse. What is the joint movement in the joint that has the hardware on it? What is the joint movement in the joint? Good question. So the first metatarsal cuneiform joint, or the joint that we're doing the procedure on. The question is, I think this is what you're saying, what is the joint movement and how does it affect that? If you're fusing a joint, how does it affect range of motion? So that unstable joint, or that first metatarsal cuneiform joint, has about 2 millimeters of range of motion up and 2 down. So it has very little range of motion. It's a stable keystone type joint. So there's not a lot of range of motion. So when you fuse the two ends together, you don't notice that there's no motion. It's not like you won't be able to move the ankle or you're not going to notice that. So it's such a minimal amount of range of motion. And the fact that it has instability, fusing it does not affect anything range of motion wise. So you still feel completely like you did before regarding range of motion. Can patient have rejection to hardware due to previous autoimmune conditions? If you have an allergy to titanium, which is pretty rare, I mean, there has been some stainless steel allergies, occasionally there's been reactions to implants, celastic, silicone, things like that. But titanium is probably the most inert metal there is. So if there's any worry, I would see an allergist or your rheumatologist and I'd have them test you, literally by, doing some sort of a metal test or putting some sort of, titanium on you for a certain amount of time and seeing if you have a reaction. But I have yet to have seen that with titanium. What is the recovery time for a Taylor's bunion fix? A lot of Taylor's bunion in the house. Shout out to Taylor's bunions. What is the recovery time? Recovery time for an isolated Taylor's bunion is typically a month in a cam walker, but you can walk right away. So walking in a boot for a month, in a month transitioning to a running shoe, and that should be it. So it's less than this, but still in a boot. Does this also correct hammer toe and overlapping toes? No, you have to address those at the same time. Totally different deformities, and each has their own correction. What at your center performs the surgery? How many procedures have you done? Other doctors who are using surgery? Who at your surgery perform? Me. How many surgeries have you done? 100. Other doctors using this? None here. There's one guy in Salinas. There's one guy in Salinas. And that's it. So you have to make sure you go to somebody who's specifically trained in this procedure. Somebody that's well-versed at both the Lapidus, which is the predecessor, and now the Lapiplasty. But at some point, everybody's going to be doing these because this is going to be the way of the future. Are neuromas and bunions related? They can be. I mean, if you have a bunion, it can make a neuroma worse. I had a patient today who had a bunion and also has a new neuroma because you're walking on the outside of your foot, and that can irritate a neuroma, which is on the outside of the foot. So yeah, they can be related due to compensation. Do you correct both feet at the same time, or do you correct both feet at once? Great question. No, I don't, especially with the Lapiplasty. I do correct bilateral feet if I do the two-dimensional correction because it's easier on the patient and you can walk on both feet right away. But with the Lapiplasty, I don't think it's a good idea because typically you will ask one foot to do more and one foot will get overworked and lead to possible complications. So I think this is a procedure that's best staged. So, I mean, I've done them 6 to 8 weeks apart, 3 months apart, a year apart. So, but definitely staged is the way to go. What if both feet need this surgery? So that's the same kind of gist. It's usually I stage this procedure, and I think that's best for the patient as far as recovery and outcome. I fractured my foot. Doctors said crutches are death traps for anyone over 20. So you can use a wheelchair or walker. Using a knee scooter is okay, but can it pick your other leg and hip? The one that is propelling scooter. Boots are hard too. They throw, okay, so I'm trying to see the question here, just so everyone is aware. Oh, no question, just a comment. Well, let me address it. Doctor said crutches are death traps for anyone over 20. I don't know what kind of doctor that is, but that's an extreme statement. I think crutches are a pretty good invention. Wheelchair, good, you know, that's okay. Or walker's fine. I've done them all. Knee scooter is okay. Knee scooter's been the best thing I've seen with my patients, but leg, hip, propelling scooter, boots are too hard, or they're hard too. Yeah, everything's hard, but so is having a painful bunion. So definitely something to think about. LOL, agree. If arthritis is present, is that cleaned up? Yes. So that's another thing. So when you address a bunion, you're trying to do a couple things. One is minimize future arthritis. The other is getting rid of any at the same time. So if you have arthritis, it's typically on the inside part of that joint, that's addressed at the same time. And if you have arthritis in your metatarsal cuneiform joint, which is that unstable joint, then that's addressed as well. So yes. What about corns that have developed between big toe and second toe? Will they automatically go away after surgery, or do they have to be physically removed? So good question. So typically I will trim them down, but yes, they go away after surgery, because part of the goal is to get that hallux or big toe to separate a little bit or give room to the second toe. So yes, it will go away on its own. Sometimes you have to trim them down a little bit because the skin has memory, but should absolutely go away. So that's another, yes, that's another symptom. How long does it take to schedule surgery after consultation? So typically schedule one or visit one, we chit chat, you know, we kind of go over somewhat like this. You know, if you decide you're interested in it, you know, we talk about all the other options. And if you're interested in it, we'll have the surgery scheduler talk to the insurance, talk to you. And then, you know, you get on the schedule, and you can work out when that's the right time from you. This is the kind of procedure that people are coming from other places for, because the outcome's much better and the correction's much better. So it really comes down to, you know, who's doing it, who's got good results with it. And I think over time, you're going to just start seeing more and more people doing this surgery, but there's no question that you can't even use this stuff until you are, you know, trained and well-versed in the Lapidus. So great procedure. Does having toenail fungus no, not at all. Let me read the question. Does having toenail fungus preclude having a Lapiplasty? No, it doesn't. It has no bearing whatsoever. We see lots of patients that have toenail fungus and do Lapiplasty, as well as all kinds of other procedures. Let's see. I think that's it. Is that it? Is that all you guys got? Is that all you got? Okay, 40 people. How much does it? Okay, wait. How much does this cost? How much does this cost? Does this cost the patient? Each insurance is different, but it depends on your deductible. It depends on how much deductible you've met. So that's something that's gone over with you with the surgery scheduler, as well as the surgery center or the outpatient surgery center. But it costs as much as other bunion procedures cost. Are you under local or general? Good question. You can do both. I typically do a hybrid. So it's called a LMA. And so it's kind of a hybrid of both of those, but there's options with either. We've done them under local, we've done them under general. I typically do kind of a hybrid. Is it covered by Medicare? Yes, 100% covered by Medicare. Thank you. Yeah, you're welcome. Let's see, somebody raised their hand. Don't know what that means, but going to click on it. Nope, going back to you guys, going back to chat. Yeah, anything else, you guys? Shout out to Alex. Alex is my scribe. She helped me with all this, and I think her mom's listening, hopefully from Florida, just to tell mom, Alex, great kid, great job. Whatever you did, number one, great kid. Even though she's not a kid, I think of her like a kid. She's the best. Yeah, I love it. I love it. You're welcome. Yeah, bunions. Oh, that's sweet. Me too. Me back at you. She's fantastic. Okay, so contact info, Monterey Spine and Joint. Phone number 831-648-7200. You can look up Lapiplasty online. My name is Scott Smith, and I'm under the Monterey Spine and Joint website, so you can certainly get me there. And come on in, chit chat more, look it up. But it's a new thing. It's going to be a great thing. Thank you. Anything else? I'm here. I'm going to be signing. I'm going to be giving free injections right out back. If anybody wants to meet me, signing T-shirts and giving free injections. Kidding. Yeah. Thanks everybody. Good stuff. You're welcome. Come on in.